Thank you, Dr. Augustine and Dr. Law. We'll see you later. All right, so we would like to invite our very first speaker uh, this morning, Dr. Y.Y. Teo. He actually has a Chinese name, Teo Yik Ying. Okay. He holds his professional degrees. He got his PhD from University of Oxford and master's in applied statistics from University of Oxford again. Okay. And he is now the Dean of Social Health School of Public Health at the NUS, National University of Singapore. He is the second Dean of the School of Public Health at the NUS, and very brilliant, smart, and modest young man. So we like him very much. So actually we invited him to visit Taiwan, to visit TMU and HPA several times already. And his topic today is promoting better health in the population with physical activity. Let's together welcome Professor Dean Y.Y.
Yeah.
Thanks very much, Becky. And it's always very nice to be back among friends again. I hope you can hear me and you can see my slides. Okay, so it sounds like you can both hear me and you can see my slides. So thank you very much for inviting me to speak about the importance of health promotion. And I think both Professor Augustine and also the Deputy DG have highlighted the importance of the mission around health promotion, particularly in its role in the entire health system. So I often believe that by the time we rely on the hospitals, or even by the time we have to rely on some of our specialist clinics, it means that our health promotion efforts have gone wrong and have not been successful. And that's why people are falling ill. And we now need urgent tertiary actions to really look after people. So over the next 30 minutes or so, I'm going to talk about the importance of health promotion using physical activity as an example. But I think it's quite important to always start off with a few fundamental concepts, particularly around public health. And this is the view of public health from my lens. And I think Professor Betty has been very kind to share about my background, but I think she didn't share something with everyone, which is that my training actually has been in mathematics and statistics. I have zero public health training. I have zero clinical medicine training. So a lot of what I do in public health, or what I learned in public health, has been through working with policymakers in Singapore and overseas, working on actual health policies and health programs that we have in this part of the world in Southeast Asia. So this is my own interpretation of public health, and feel free to disagree if you don't agree with my views. So I believe that public health fundamentally is around three activities. It is about preventing, and that's where a lot of the health promotion comes in, making sure that we keep people healthy for as long as possible. The second part is for people who are starting to be ill. How do we identify this group of people as early as possible? So we screen people early and we identify disease as early as possible. And finally, it's for people who already have conditions such as cancer, hypertension, diabetes. How do we manage this group of people such that we prevent or we slow down their advancement towards complications that has to do with the eyes, that have to do with foot amputations and so on. But at the same time, it is not just three activities, because we can't do these three activities without understanding what works and what don't. We have a lot of policies, programs and interventions. How do we know which are effective? And more importantly, how do we know which are cost effective? Meaning for every dollar that I spend, I'm actually saving something in return for my spending. These are very important concepts in public health. The second part is really understanding how do we communicate to the people to increase their understanding on how do they look after themselves, how do they come forward for health screening, and how do they manage their disease when they're ill. But importantly, when I talk about communication, it is never just to the people. it is as important for us to be able to communicate to the policymakers, to the politicians, because they are the ones who controls the money, who makes the decisions. So this process of communication is never just to the people, but equally to the policymakers, to people in the industry as well, to try and motivate them to perform differently. And finally, I talk about financing quite a bit. It is about financing. How do we make sure that our health system has the financial resources to keep it going in a sustainable manner so that we don't bankrupt the system? So all of this actually is what I believe is the whole comprehensive picture of public health. But when I talk about the public health, I must also mention what are the fundamentals. Because in public health, we believe a lot in relying on data and evidence to push for public policies. We don't choose a public policy because we like it, but we choose and push for a public policy because the data and the evidence show that it is going to be effective and is helping to save lives and prevent disease. The second is really public health fundamentally focus on prevention and actually focus on systems thinking. This is very different from clinical medicine, because clinical medicine, we focus on saving the life that is in front of me. Some of the decisions that are taken to save the lives may incur a lot of money. If we think about cancer therapy, some cancer therapies are very expensive to save one life. At the systems level, we have to start thinking, can a country afford to keep giving such life-saving drugs for cancer when each dose could cost $1 million and could instead save many other lives in different contexts? I talk about focusing on some key principles. There are two principles that I thought it would be useful to start off with in any public health lessons, which is DIME and SAVE. DIME stands for design, implementation, monitoring, and evaluation. This is actually a process that happens in public policy making. We have to design a policy, we have to implement a policy, and more importantly, we need to collect the data, and that's where the monitoring starts, to understand, is it effective? Is the policy that we push forward effective? So DIME is a very important principle in public health, just as SAFE is. SAFE stands for sustainable, adequate, fair, and efficient. So I'll come back to SAFE and DIME later on in a bit, because I believe those are very important aspects as we start to think about the importance of health promotion. Now, in academia, people always talk about academic papers, research papers to get promoted. But actually, public health academia is extremely different. We focus on outcomes. You can publish a very good paper in a top journal, but if it doesn't lead to actual practices, change in policies, change in programs, actually, if it remains just as an academic paper, that is a very poor piece of public health research. A good piece of public health research doesn't just start off with a research paper, but it goes all the way to see how can we change understanding and practice of public health in reality. So there are different things that we do in public health, such as we generate the data and evidence. We understand the data and evidence from different countries, because different countries have also done a lot of public health research. We look at what is the impact if we try to do the same, be it tobacco control, be it promoting more physical activity in our country. We need to understand and model what is the impact going to be. We need to know that we are collecting the data to understand the effectiveness. How do we communicate this to our people? And finally, is the systems as a whole ready to adopt this process of evaluation, of financing, and so on? So let's start off with how government thinks about health policies. These are the priorities of government. The priorities the government think about is that health policies and programs cannot bankrupt the government. It must be sustainable. The second is that governments actually do aim to provide adequate care, such that it's sufficient to protect people from across the whole age spectrum, the whole life course, from birth to cradle, from cradle to grave. It has to be fair, because we want our policies and programs to ensure people are able to access care equally and equitably. And finally, it has to be efficient. I talk about making things cost effective, meaning when I spend $1 on encouraging people to be physically active, I know that downstream I'm getting $2 or $3 of health savings in return. It may be in future, but I know that the return on investment is $1 in, $3 in return. But when we think about national programs, so earlier on I talked about the government lens when they're thinking about policies. Now, when we think about the programs that we design to execute some of these policies, these are some of the consideration we need to have. And that's where the DINE principle comes in. We need to design our health programs such that it is rolled out with equality in mind. Now, I focus here on equality because on the design side, we want to ensure that we are allowing everyone to have equal access to the benefits that we're putting forward, be it in the nutrition, for example, a milk program that we roll out for children at the age of 6 or 7 years old, or a COVID-19 vaccination program that we design it such that it's equality in mind, meaning everyone has equal right to access it. Now, then comes the implementation, because the way that we implement a program, it's where we look at whether we are able to achieve equity in our outcomes. So people always talk about these two concepts of equality and equity, but actually fundamentally they come in at different stages of rolling out a program. Equality comes in at the design stage. Did I design it in the first place such that everyone has equal access to it? But when we want to roll this out for equitable outcome, it is the implementation. We want to make sure that the last 10% of the population that is hardest to reach will still have the chance to access the benefits. That is where we talk about equity. And equity is a concept that is to do with implementation. And then finally, we need to monitor, because then we know, is our implementation equitable? Is our design equal in the first place? Whether we are able to reach out and penetrate all the people that we want to and get the success that we want. And finally, evaluate. When we talk about evaluating programs, it is not just for effectiveness. It is actually also for cost effectiveness. I talk about whether it is better, it is going to help the country save money in the long term. That is what cost effectiveness means. Now, I mentioned about this concept of equity and equality. Again, I want to highlight this because I believe in a health promotion program, this concept of equality and equity is extremely important, as I will describe throughout my lecture. Equality is fundamentally an input-driven concept, meaning when I'm designing my policies and my programs, do I have equality in mind? Equity is actually where what we achieve from the outcomes perspective based on our implementation process. So vaccines programs, let's start off with equality. Equality means that everyone in Taiwan has equal chance to access the vaccine, and the government put in place, bought enough vaccines such that there's sufficient supply for everyone. That is an equality program, an equal vaccination program. But in terms of equity, there are minority groups in Taiwan. Some are living in more rural areas. It is harder for them to get hold of the vaccines because they are in rural areas. Perhaps the vaccination is in vaccination centers that are in the cities. So in that case, the implementation needs to address the need of delivering the vaccines to different groups of people. And I'll use this example that we have in Singapore. We have an equality-based vaccination program for COVID-19. We have 84 vaccination centers in a very small country like Singapore. So everyone can turn up at the vaccination center and get their vaccines free. But there are bed-bound people, homebound people that cannot leave their home because they are frail, they are unable to move about. So an equity-based implementation means that now we have to increase the cost. We need to pay more to send doctors and nurses to people's homes to actually deliver the vaccine. So by making the vaccine available for people to get, it aims for equality. But by making sure that everyone in Singapore is able to get that vaccine, that I put in place certain access program to reach out to those hardest to reach, the last 5-10% of the people that are not vaccinated, that is aiming for equity. So now you think about a health promotion program, whether it is in nutrition and in physical activity, in tobacco control, you will start to realize that there are many programs that we have, whether it is in Taiwan or in Singapore, we have equality in mind when we design it, but we seldom have equity in mind when we implement it. Now, what is precision public health? And this is actually a new framework that is going to help address some of the issues around equity. Because precision public health is really trying to focus the use of technologies. It could be the use of sensors, mobile phones, genetics, the use of data to really try and understand who needs help at which stage in their lives. Some people may need to be some people may need to go for breast cancer mammogram screening earlier. Some people may only need to go for mammogram screening later because their inherent risk is lower. So by having a better use of technology, we are able to deliver better public health care such that things become more equitable because we are aiming fundamentally for the outcomes. And we also have better ways to really understand the population as a whole, to learn about our policies and programs effective. This is actually precision public health. It is nothing different from what I talked about earlier on in terms of the public health activities, what we do in public health, but precision public health is just now the use of technology to deliver what we've always been doing: preventing, screening, control and management, thinking about financing, thinking about communication, and thinking about effectiveness, understanding effectiveness and cost effectiveness. But now we make use of technology. So now let's start off focusing on physical activity. One of the use of technology and data is that we now have better understanding of why people are ill and what caused this illness. So this is from the Global Burden of Disease study. I took the latest data from 2019. You could see on the right panel that there are a range of medical conditions. Those that are in red or in pink generally reflect infectious diseases or maternal child condition. Those that are in shades of blue are generally your NCDs, your non-communicable diseases, such as diabetes, cardiovascular diseases. Now, I'll just focus on the top causes. The top causes include high blood pressure, smoking, low birth weight, and so on. But I will just highlight high body mass index, meaning obesity, overweight and obesity, as well as low physical activity, are actually amongst the top causes of morbidity and mortality. These are the reasons why people are less likely to achieve a high productivity in their life. When we think about physical activity, there's always this question: how much should we be thinking about? How much should we do? So all of us here in the lecture room, in the hall, are public health practitioners, are people working in health promotion. I hope all of you at least know that as adults, we should be aiming for about 150 minutes of moderate to intensive activity in a week. That's 150 minutes in a week, or about 25 minutes every day. So personally, I try to exercise at least 25 minutes in a day. But the question is, how many of us are able to keep to these recommendations? When we don't keep to these recommendations, there is a cost. And many societies, many countries actually learn about the cost. That, for example, it was estimated in the UK, physical inactivity in the population is costing the country about 33 billion US dollars. So there's all this estimation in China, 20 billion US dollars, in USA, which is a much more sedentary country, 147 billion US dollars. We also understand that how we educate people, how we influence people to be physically active really relies on what we do to them during the first 10 years of their life, children. So I have two young children at home, now they're 11 and 13. I do see that it makes a difference if you influence children from young, that physically active is part and parcel of your life, just as waking up in the morning, brushing your teeth for dental hygiene, having adequate sleep, going for your fruits and vegetables in the meal. All this together with physical activity are what we educate our young children from the beginning, because this creates a lifelong impression and commitment to healthy living, not just to physical activity, but to fruits and vegetables intake, to rejecting tobacco, rejecting alcohol. These are important attitudes. So what do a society and how does a country really address an issue such as physical activity health promotion? I will illustrate through a few steps. The first step is always understand the problem, understand the practice and the trends in the country. How do we know that our people are physically active or physically inactive? This is where now there are many ways that we can measure. In the past, we rely on questionnaire that we give population surveys. So we get people to fill out a survey to say, how often do you generally exercise, how many days, for how long, and so on. But when it comes to exercise, we know that people tend to overestimate that they exercise a lot. So these days, there are all these trackers, including from watches, from sensors that you can wear on your wrist to really track. And we have seen the difference in how using paper questionnaire versus actual trackers, what it says about people. So this is an actual study that we did in Singapore. In 2010, when we used paper questionnaire to ask people, do you think that you exercise enough? So generally, enough, it's 150 minutes and above. So about 61% of the population claims, they reply in the questionnaire that they are physically active. Only about 40% claims that no, they fail to reach this 150 minutes. Now, if you think about it, 60% claim that they did 150 minutes of exercise in a week. That's pretty high. So you tend to end up having a good sense of the population while people generally are exercising. So we reproduced this study in a research program that we have in the school, where we again get people to answer on questionnaire how much exercise that they did. So in our study, about 3/4 or about 75% of the people say that they are physically active, 150 minutes and above. But for all of the participants, we also gave them a tracker to monitor their heartbeat, to monitor their physical activity. And it turns out that the truth was actually the opposite. It was only 1/4 of the people that was physically active. So this became very important, and it actually led to a lot of changes nationally in Singapore, because subsequently we decided that actually asking people to answer questionnaire about physical activity is no longer going to be accurate. We should be moving to better collection of physical activity data. So what we did was that nationally, we started programs, national programs on physical activity. So in Singapore, given that we know that there is a cost to physical inactivity, we invest in getting people to increase their physical activity. And as part of this increasing their physical activity, we actually have a way to track their physical activity, to monitor that. What we did was we gave everyone a step tracker. And that's what we call the National Steps Challenge. It is one of those that you wear on your wrist. As you walk about, it starts to count how many steps you take, what is your heartbeat, and so on. So we were able to estimate whether people were taking the steps and what were their heart rates like in terms of moderate and intense physical activity. So we actually also incentivize people. We gave points if they meet certain targets. If they did 10,000 steps or more in a day, they get certain points, and the points actually translate to financial monetary rewards. And actually this became quite prominent worldwide because this was the first time a country actually gave money to get people to exercise in a whole nationwide program. So out of the whole country of about 5 million people, about 40% of the people actually signed up for the National Steps Challenge. So the question then is, I now have national programs on physical activity, but if you recall what I mentioned earlier on, the question is, we always need to understand, are these effective? So we've always known that when you use technology to nudge people, you can start to realize that, oh, this person hasn't been moving for the past 60 minutes. Send them a reminder over their phone to say maybe it's time to move about. Ask them about their daily activities and so on. The question always is, if I give people money to be physically active, now these people may be physically active during the time that I'm giving them money, which is for about 3 months, 4 months. But if I stop giving them money, what happens? We realize that actually once you stop giving the incentive, generally people start to go back to normal behavior. So the question now is, for National Steps Challenge, is it equally the same problem that initially we give them the program, we sign them up to the program and start giving them monetary incentives? So you could see this is actually the actual data from the National Steps Challenge. And this is part of the process of monitoring and evaluation. You need to monitor to get this data. And what we saw was that before people sign up for National Steps Challenge, generally they were taking about 1,000 steps less than when they started the National Steps Challenge. Now, what happens after National Steps Challenge ended? There was a gradual decrease. So one of the most important impact of COVID-19, Professor Augustine talked about it earlier on in her introductory remarks, was the impact of COVID on health promotion and health-seeking behavior. Because worldwide, there was a huge impact. Alcohol sales went up, tobacco sales went up, more people started smoking. There was a big problem with mental wellness. There were more reports of mental fatigue and mental problems. Physical activity decreased tremendously because many countries shut down. There were lockdowns imposed in many countries, including Singapore. So you could see this is the physical activity steps count that we observed in the entire country that took part in the National Steps Challenge. The two columns that were colored in pink were when Singapore imposed a significant lockdown. So you could see that when we locked down, the national steps dropped tremendously. We started at a high of about 9,000 steps on average in the population per day to only about 4,000 steps per day. That is a significant drop in physical activity. We estimated that for people, this drop will lead to quite a significant weight gain if they didn't actually change their diets as well. If they're still eating the same as they were doing, 2,000 calories or 2,500 calories per day, it will lead to quite a significant weight gain over a period of 6 months. And we saw this happen in Singapore. This would similarly be observed in many countries because of COVID-19. Step counts, we saw that even when we look at moderate to vigorous physical activity, we saw the same as well, that there was a decline. So anytime that a country imposed a lockdown because of COVID-19, you don't just bear the cost economically in terms of economic figures, economic sales that were not made because of the lockdown. You actually bear a health cost from the fact that people are not going to work, not moving about as much in society, the level of physical activity actually drop. This is the monitoring and evaluation that is important, because if you didn't even have the means to collect the data in the first place, you will not be able to make such observation and start to model what this means 5 years, 10 years later to problems such as diabetes, hypertension, cardiovascular disease, obesity, and so on. Because of this, we are now able to model and project ahead the economic cost from diseases as a result of reduced physical activity. And what this means is that moving forward, once COVID-19 is less of a problem in Singapore, we actually now need to ramp up a lot more on our health promotion activities in physical activity, in nutrition, in alcohol, in sodium, and in tobacco, because these are some of the areas that we have seen problems emerging during COVID-19. And I think the question here is now, countries such as Taiwan, Indonesia, Malaysia, Singapore, do we have the mechanism to collect the data on physical activity, on nutrition, on tobacco, on alcohol, such that we understand the scale of the problem during a time like COVID-19? Next is actually around public-private partnership, because increasingly there is a lot of private sector innovations in health promotion. We talk about the use of monitors and sensors. Equally, there are now nutrition companies that are coming up with new products that are high fiber, low GI, that are very helpful in health promotion. In Singapore, we had the privilege to partner with Apple on rolling out the use of an Apple Watch to actually perform what we call precision monitoring. And this precision monitoring, it most fundamentally will monitor physical activity, the amount of sedentary time, the amount of time that a person is standing up, but it will also send health-seeking messages such as health screening, going for vaccination, HPV vaccination, even understanding your sleep pattern and so on. And a lot of this actually looked at, I talk about the activity, the rings, closing 3 rings on your mobile, on your Apple Watch, and it actually helps by incentivizing people who sign up for this program. It's called Lumi Health, by giving them again financial rewards to encourage them to take up physical activity. And my school have been very privileged that we have been identified to help to evaluate whether this is effective, cost effective, and then subsequently the cost benefit to the country. I talk about the evaluation. So let's talk about first the National Steps Challenge. When we start to think about effectiveness, the question always is, the long-term success is always, are we able to reduce future disease burden? And that means in future, in diabetes, in 2030, 2040, 2050, will there be a lower incidence of diabetes because of some of the actions that are taken today in 2021? And this has to be done through a process of modeling, where we look at the uptake, we look at some of this increase in steps, and how does this translate or does not translate to reduction in disease burden. How do we know what is the tipping point? Is 1,000 steps more enough for us to justify spending $100 million to get people to walk more? Or is that 1,000 steps more a day actually insignificant? All of this, we actually need to understand the epidemiology for us to project success. And it's also not just the success in disease burden, it is also the success in averting complications from diseases. Understanding what does it mean to individuals in terms of their hospitalization bills. And this was an actual study that we performed in Singapore, looking at physical activity in the elderly. So there was an intervention that we provide more exercise to the elderly, and we saw that people who undergo the intervention actually end up having a lower bill size. They save on average about $30,000 compared to people who were not, the elderly who were not physically active. It's not just savings to the individuals, but it's also savings to the hospitals, because we saw that over time, we were able to look at the actual saving in 2020 was around 26 million because of a physical activity program for the elderly. And we project that if we keep this going, come 2030, the savings will be about 55 million. 2040, it will be 90 million. We were able to also understand to the individuals, not just the cost, but also the increase in lifespan, in healthy lifespan. And it was an increase on average of about 1.6 years. So these are the ways that we are able to evaluate, is a physical activity program successful or not successful? And understanding this actually allows us to now ask the government for funding to support a program like the National Steps Challenge. So we looked at the cost effectiveness of the National Steps Challenge, looking at both how much of it will help to save direct costs from direct medical costs, such as going to the hospitals for hospitalization because of diabetes, because of hypertension. In return, we have to pay out because the National Steps Challenge costs money. On average, it costs about $100 million a year to run the National Steps Challenge program. There are also indirect benefits, because if a person is healthier, they take less medical leave, there's less loss in productivity, there's less loss in productivity because people died early or people got ill and they had to retire early. So by understanding all of this cost and benefit, we were then able to really understand what is the benefit of a program like the National Steps Challenge. And we were able to estimate that it appears to be cost effective, and it's not just cost effective, it is actually cost beneficial, meaning there is an active return on investment that is much greater than one. And that means that this becomes a program that is worth subsidizing by the government on an annual basis, all the way until 2050 and so on. So these are some of the considerations that we have in mind. So in summary, when I talk about public health practice and policies and programs, I focus on physical activity, but I hope you can see that it is not just physical activity. It is the same for nutrition, for alcohol, for tobacco control programs, and other programs, including health screening, vaccination. Many programs are designed for equality, but how we implement it is where we make a difference between whether it is equitable or not. When it comes to health promotion, working just with the government sector is not enough, because a lot of the innovations actually comes from the private sector. And that's where the private sector partnerships becomes very vital. At the heart of it, public health policies and programs must be grounded in data and evidence. And it is important to look at data and evidence from your local context, because what works in a country like Singapore may not work in Malaysia or Indonesia. Equally, what works in the United Kingdom may not work in Taiwan or in Singapore. So we need to understand the local context and to forecast what is the impact locally. I'm going to use a very simple example of mask wearing again. In a country like Taiwan, Singapore, we know mask wearing has been very effective in protecting against COVID-19. Rather surprisingly, mask wearing was found not to be that effective in Scotland compared to a country like England that wasn't relying a lot on mask wearing. I believe it is the context of implementing this mask wearing that matters a lot. The cultural context of whether people are used and consciously wearing their mask properly. And finally, we never run public health policies and programs without understanding the impact. Is it successful? Is it reaching out to the people that we want? So that is why the importance of monitoring and evaluation cannot be undermined. We need to always understand, are the policies and programs that we put in place achieving the intended impact and effectiveness? So with that, I end my lecture, and I'm very happy to take questions. So thank you once again for the opportunity to share some of the thoughts and experiences that we have in Singapore around physical activity in health promotion. Thank you.
Thank you, YY, for the very inspiring talk. And so now we open the floor for our Q&A session. Any questions from the audience? Okay. Do I have some helper to hand on the microphone?
I'm from Indonesia. Thank you for the lecture today. I would like to ask about the things that it's interesting because from the first, you said before that the red mark the COVID phase CP period, first and second. If you see the median daily step count, it doesn't really increase significantly. However, the median weekly moderate to vigorous physical activity looks quite similar. So I'd like to know what was happened during the phase 2 of COVID pandemic in Singapore. Because it's quite, the decrease is not really significant compared with the first phase. What was happening during that time? Is there any government policy or? That's my question.
Okay, so thanks for the question. I'm relying on your moderator to share the question because we haven't heard, I can't exactly hear the question very carefully, but the moderator has very kindly typed that the question is, what was happening during the second shutdown phase in Singapore and why did the steps not change as much? So Singapore, we underwent a major shutdown in 2020 from April last year, in April last year. And this happened for 2 months until June. In 2021, which was when I believe the second shutdown phase that you were referring to happened, it was not a full shutdown, but people were just asked to work from home. The shops, the parks, everything else was actually open and people were allowed to move about in public. It was not the same as the first shutdown that happened. So there was a decrease in physical activity in the second phase, but it was less dramatic than in the first phase. In the first phase, it was a big drop in the physical activity because most people actually ended up just staying at home to avoid being infected.
So any other questions? Okay, one more.
Hello. Hello, Dr. Teo. Thank you so much for your presentation. I'm Farhan Rawi. I'm from Malaysia. I would like to ask you 2 questions pertaining about National Step Count Challenge, right? So I'm very interested about the program. And I was wondering how about the public acceptance on this program regarding issues about the privacy or security for this program, and how do you navigate expectation and also decision making in terms of this kind of promotion? Thank you.
Right, so thanks again to the moderator. I understand that the question was around whether the public was worried about the privacy and security of the data for the STEP program. Not really, because what data was actually collected as part of the STEP program. The STEP counter actually doesn't have the identifiers. So the data is automatically uploaded whenever there's a Wi-Fi connection. So it was, in terms of the confidentiality, the Health Promotion Board in Singapore was able to assure people that none of your medical data will be collected. It is only with respect to your step count data that will be submitted. So the amount of data that was collected from each individual was actually very little. It was mainly mobile phone number as well as the step tracker identity. So by doing that, actually that reduced the problems of leak of security or problems with confidentiality. Nonetheless, there were people who actually did raise the issue around, will my medical data be used against me, particularly against insurance companies and so on? Because nowadays there are insurance companies that are also looking at the person's physical activity profile in deciding premiums. So those were assurances that were made to individuals that when you sign up for the National Step Challenge, the data is used only by the Health Promotion Board and never shared with any private sector.
Due to the time limits, I'm afraid we have to close the Q&A session now. But still, YY is very active. You can just email him, and I believe he will be very happy to answer the questions. And also, YY, we miss you here and hope you can visit Taiwan soon, or we will come to Singapore to find you. All right. Thank you for today's speech. Thank you again.
Thank you, everyone, and thank you, Betty. I look forward to seeing you and Albert in Singapore again.